We've talked about what's under the umbrella, and now I want you to know what sometimes gets put under the umbrella, and some of it doesn't actually belong there. But people will say it belongs there because we used to put everything under the umbrella we didn't understand. And the first thing I want to talk about are pseudo dementias, things that sort of look like dementia but actually aren't and can be fixed. So, for instance, if a person has something that happens like a normal pressure hydrocephalus, it is possible if we fix that, the dementia goes away because it actually wasn't a dementia. If somebody has a stroke or a heart attack and their brain isn't working well during that time and we repair what went wrong, well, they're back. And they're back because what they had was a brain change that came from something that happened to their body, to their brain. But when we fixed it, ta-da! Now, there are some things we don't know as to whether or not it is or it isn't, and we are learning about that. What we do know is that people can have anxiety or depression, a mental health consideration, a change in their sense of emotional wellness. That can look like dementia, and it might actually occur if the person gets dementia, but it's a different condition, and we would want to treat it as the condition that it is within the confines of living with dementia. But we also have people who simply have anxiety or depression, and when we manage the anxiety or depression well, it turns out they don't have dementia. Now, a third grouping under there is medication-induced changes in brain function. And it turns out that there are many medicines out there that can cause changes in function that look a lot like dementia. And some of those medications are because they have an impact on the brain that sedates or calms the brain to such a point that the brain can't function as well. So medications that are sometimes used to treat anxiety or sleep disturbances can have a hangover effect in a brain and can make us think, well, the person's developing dementia. So managing medications carefully and thoughtfully really are important. And that means we've got to know what meds the person is on and the combo of meds. And that's where working with a teammate who's really skillful in pharmacy work, especially if a person has multiple physicians and has health conditions that might necessitate the need for those medications. Sometimes it's a specific medication that we need to know about. And then we have mental health issues. So somebody who has schizophrenia, has bipolar disease, has mania, if that's the case, they may have an episode of acute illness called a psychosis, and a psychotic episode. It's super important that we know that's not dementia. That's that health issue. But at the same time, it gets a little confusing when somebody has a delirium. Now, delirium can happen after a surgery coming out of anesthesia. It can happen after an acute illness. It can happen after an electrolyte problem in the hospital. It can happen after you don't get sleep day after day, night after night. It can happen when you have taken in poison and you didn't realize it, whether it's heavy metals or whether it might be a chemical that you breathed in or a virus. What we want to keep in mind is this may or may not actually be related to a dementia, and it always should get a good evaluation, particularly if somebody has an infection or inflammation. It can affect brain function. And we want to be thoughtful that that is not dementia, and that deserves a workup. As we move toward the end of dementia, we may choose not to intervene in the same way we would have early in dementia, but it doesn't mean we shouldn't acknowledge that that is not in and of itself the dementia. Now, finally, there are dementias where some of these odd behaviors do occur. That's important to note that that's a symptom of that person's dementia, and that is part of their dementia. And we need to learn how to support someone with that symptom rather than taking them to the ER or reacting in an emergent way when it's not an emergency. That was a lot. Let me just say, ultimately, if you're going to advocate and be a partner with someone living with dementia, it's also important to know what dementia is not. So when somebody says, oh, well, that's just their dementia, you have enough awareness to go, I think I might want a second opinion on that. Or could we at least look at this? Because without that advocacy, we may allow someone to struggle with a symptom that actually is not due to their dementia and could actually be treated and improve their quality of life and their abilities. We become often a gatekeeper for exploration. It's a serious job. Take a deep breath, let it go, but don't let go of the possibility that you can make a difference, because you can.